Yeah.
Okay, Dr. Bonini is a sport physician, a PhD in respiratory diseases at Sapienza University in Rome. He is right now working at the Royal Brompton Hospital, Imperial College of London, and he has recently published a meta-analysis entitled Beta2 agonist for exercise-induced asthma. So, Dr. Bonini, please, can you resume the main results of your meta-analysis?
Hi, Silvia. Thank you very much for the kind introduction. As you said, we recently published a meta-analysis on the Cochrane collaboration, which was essentially aimed to assess the efficacy and the safety of beta-2 agonists in the pretreatment of exercise-induced asthma. And the evidence emerging from the meta-analysis derived from 53 studies. 45 of them addressed an acute beta-2 agonist administration, while 8 addressed a chronic administration of both SAB and LABA. As far as it concerned the acute effect of beta-2 agonists, we can say that for sure these molecules are effective in treating exercise-induced bronchoconstriction, as shown by the primary endpoint of the meta-analysis, which was the maximal FEV 1% fall. And this data was confirmed by secondary outcomes, like those related to other pulmonary function parameters and by the number of subjects protected. At the same time, we can say that these molecules are safe to be used because all the side effects reported in relation to the administration of beta-2 agonists were just minor and not directly related to the molecules, and anyway were not significantly different from those related to placebo. As far as it concerned the 8 studies addressing a chronic administration, on the other hand, it was not possible to plot them in a meta-analysis because there were just few studies and they were quite heterogeneous. So what we found is that even though the first administration of a chronic treatment appeared to be effective, after a while, even after a 2-week treatment period, subjects developed tolerance to the drug effect. And the other fact is that safety of a chronic administration should be further investigated because there is no enough evidence on this aspect.
Okay, thank you. And have you seen is there any predictive marker for the onset of tolerance of the bronchoprotective beta-2 agonist effect?
What I can say about this topic, of course, it was not something strictly related to our meta-analysis, but we published a paper in the Blue Journal where we saw that baseline levels of nitric oxide could be considered a good predictor for developing tolerance. At least we studied the effect of salmeterol for a 2-week treatment period, and we saw that splitting subjects according to the latest ATS guidelines on the effect of exhaled nitric oxide, we saw that those with values higher than 50 part per billion developed tolerance significantly more than those with values lower than 25.
Okay, so thank you. And which are the other alternative treatments for exercise-induced asthma?
So I would say that good alternative options could be represented by inhaled corticosteroids, especially in subjects with underlying exercise-induced asthma, so which it means with underlying clinical evidence of asthma. These kind of drugs could be administered even in monotherapy or in association with long-acting beta-2 agonists in subjects with moderate to severe underlying asthma, or even leukotriene modifiers or chromons.
Thank you. And just the last one, Dr. Bonini, in your opinion, which are the lines in exercise-induced asthma which should be followed in future research?
So I think that could be valuable to further study the difference between phenotypes to assess in a proper manner if exercise-induced bronchoconstriction and exercise-induced asthma are different phenotypes. And for sure it could be useful to identify predictive markers of efficacy and safety of this drug, identifying subjects responders and differentiating them from those non-responders. It could be useful as well to find new evidence regarding studies related to a possible genotype effect or the effect strictly related to some other potential confounding factors like concomitant therapies.
Okay, thank you very much, Dr. Bonini, and congratulations for your work.
Thank you, Silvia. Really kind of you. Bye.
Bye-bye.